Dear our Prof. Doctors, dear colleagues, good afternoon. At first, I want to introduce myself. My name is Mohammed Shaheen, Assistant Fellow of Radiology, National Hepatology and Tropical Medicine Research Institute in Cairo. I want to send many thanks to Prof. Dr. Mohammed Fawzi Tolba, as well as Dr. Safa Al-Mandou, for giving me this opportunity to be here today. At first, our talk today is about cholangiocarcinoma. Objective of the talk: definition, epidemiology and risk factors, clinical presentation, pathology including anatomical classification and morphological classification, radiological features. What is the cholangiocarcinoma? Cholangiocarcinoma is an adenocarcinoma of the bile ducts. It arises from columnar epithelium lining the biliary ducts. Overall, it's a rare tumor with much high rates at Southeast of Asia and Middle East. It's the third most common hepatobiliary malignancy after hepatocellular carcinoma and gallbladder carcinoma. It corresponds about 15% of primary liver tumors and 3% of all gastrointestinal tumors. It presents in old age between 5th and 7th decade of life with mild male predilection. What's the people at risk of cholangiocarcinoma? There's three groups of people: autoimmune disease, congenital anatomic anomalies, and infection. The first group was autoimmune disease like primary sclerosing cholangitis, especially in Western countries, ulcerative colitis, and primary biliary cirrhosis, while congenital anatomic anomalies like Caroli disease, choledochal cysts, anomalous pancreaticobiliary junction, abnormal tumor suppressor genes, neurofibromatosis type 1. The last group is infection with biliary parasites or recurrent pyogenic cholangitis, especially in Southeast of Asia countries. What's the clinical picture of cholangiocarcinoma? Mainly painless jaundice, maybe right upper quadrant abdominal pain, weight loss, fatigue, maybe palpable mass in very large tumors. Unfortunately, it has very poor prognosis and high morbidity. Pathology of cholangiocarcinoma. According to anatomic classification of cholangiocarcinoma, this is classified into intrahepatic and extrahepatic. Intrahepatic, which accounts for 10% of cases, while extrahepatic accounts for 90% of cases, which is subdivided into proximal perihilar, which accounts for 70% of cases, and distal cholangiocarcinoma, which accounts for 20% of cases. Distal or proximal to what? To the insertion of the cystic duct. These diagrams show the anatomical location of cholangiocarcinoma. In the first and second image says intrahepatic cholangiocarcinoma, while the third image perihilar proximal cholangiocarcinoma, and the last image distal cholangiocarcinoma, distal to the insertion of the cystic duct. Another diagram, the intrahepatic portion represented by green color, this is the intrahepatic cholangiocarcinoma, while the yellow color represents perihilar cholangiocarcinoma, and the blue color represents distal cholangiocarcinoma, proximal and distal to the insertion of the cystic duct. Morphological classification: the Liver Cancer Study Group of Japan classifies the cholangiocarcinoma angulous characteristic into three types: mass-forming, periductal infiltrative type, and intraductal growing type. Some simple information about each type: the mass-forming cholangiocarcinoma, it will be well circumscribed, large lobulated margin mass, usually affect intrahepatic biliary radicals, as seen in the diagram. The second type is periductal infiltrative cholangiocarcinoma. Grows along the bile ducts, which is elongated, branching, and spiculated. Usually affects the central and extrahepatic biliary ducts, like seen in the diagram. The last and most rare type, intraductal growing cholangiocarcinoma. It will be small sessile bulboidal growth in various segments of bile ducts, usually affects the central and the extrahepatic biliary radicals. Another diagram shows the three types of morphological appearance of cholangiocarcinoma: mass-forming type, usually intrahepatic; periductal infiltrative type; and the last type is intraductal growing type. Radiological appearance of different types of cholangiocarcinoma. We will talk at first of mass-forming type. Mass-forming type appear as infiltrative large mass hepatic focal lesion with delayed enhancement in contrast enhanced CT or dynamic MRI. Like seen in this film, there is large hepatic mass occupying most of the right hepatic lobe with delayed enhancement at the delayed image. Capsular retraction. This large mass, hepatic mass, represented by yellow arrow, and this overlying capsular retraction due to fibrous effect of the mass over the overlying capsule, causing retraction of the overlying capsule. Bile duct dilatation in upstream of the tumor. As seen in the white arrows, there's a mass of cholangiocarcinoma and related dilated biliary radicals related to the mass. This is very rare in peripheral tumors, as there is lack of biliary system and not associated with other primary tumors or metastases. These are another examples of hepatic mass at the right image, hepatic mass with dilated biliary system, and the other image, hepatic mass with capsular retraction. These hypodense satellite nodules in about 65% of cases, which are differentiated from metastasis. At metastasis, there's primary tumor, and the lesions are variable size and diffusely scattered at the liver. While in hypodense satellite nodules associated with cholangiocarcinoma, there's mainly small size, hypodense, and related to the main mass of cholangiocarcinoma. Mass-forming cholangiocarcinoma causes vascular encasement without formation of visible tumor thrombus, unlike other primary hepatic tumor like HCC, which cause tumor invasion of the blood vessels and the tumoral thrombosis. Here, there's mass of cholangiocarcinoma and the blood vessels seen inside with encasement, not invasion. Differential diagnosis of mass-forming type of cholangiocarcinoma with other types of masses, hepatic masses, with late enhancement, like cholangiocarcinoma, hemangioma, and liver metastasis. Capsular retraction is present in cholangiocarcinoma and not appear in hemangioma or liver metastasis. Biliary radical dilatation present in cholangiocarcinoma, not appear in hemangioma or metastasis. Peripheral nodular enhancement, which is present in hemangioma, not present in cholangiocarcinoma or liver metastasis. Hypodense satellite nodules, which are present in cholangiocarcinoma, not present in hemangioma or liver metastasis. And the last, presence of primary, which is present in liver metastasis, not appear in hemangioma or cholangiocarcinoma. The second type is periductal infiltrative type or stricture type. Usually involves the common hepatic duct. It's seen to be a Klatskin tumor, known to be Klatskin tumor or hilar cholangiocarcinoma. This dilatation of the biliary system with abrupt caliber changes, which is seen a non-continuity of biliary system, When we track the dilated biliary duct in these images, there is sudden abrupt capillary changes and non-continuity of biliary system. On CT, these tumors are very difficult to be visualized, unlike MRI may be more visualized. That means of this patient already have stent when first come to do CT, which makes the visualization is even harder. As seen in this image, there's a stent is seen with no definite mass could be detected. Classification of periductal inverted vibe or Klatskin tumor, called base muscular classification. The first classification, type 1, is a tumor is common at common hepatic duct, not reaching the conjoint of right and left hepatic duct, the confluence of right and left hepatic duct. While type 2, reaching the confluence of right and left. Type 3A, reaching the confluence and extending to the right hepatic duct. Type 3B, reaching the confluence and left hepatic duct. Type 4, reaching the confluence and both right and left hepatic ducts or multicentric lesion. This is another diagram. Some examples, this type 1 diagram and the MRCP. The lesions is in intrahepatic biliary radicle. The confluence is free, no lesion at the confluence, while the lesion is not reaching the confluence. This is type 1 base muscular classification. Type 2, the lesion reaching the confluence of right and left hepatic duct, but not extending inside them. Type 3A and type 3B. Type 3A, the lesion extending to the right hepatic duct, while 3B to the left hepatic ducts. Type 4, the lesion at the common hepatic and both right and left common hepatic ducts. The resectability of the cholangiocarcinoma or Klatskin type of cholangiocarcinoma in particular, extension. The tumor is unresectable when extension into secondary biliary ducts, into hepatic parenchyma, into hepatic artery or portal vein. Occlusion of the main portal vein, any two nodes around the pancreas, or distant metastasis. The last and most rare type, intraductal cholangiocarcinoma. These very rare tumors, they present as intrapapillary mass with biliary dilatation peripheral to the mass. As seen in this MRCP, show intraductal periboidal mass with localized ductal dilatation. Reference. And thank you.
Thank you, Professor Mohammed, for this nice presentation.